Shall we start then? Yes.
Okay, hello. Hello, okay. Today we are on the third session of ANVIS and now virtual classes. So today we are having Dr. Mahesh Raj Joshi, who is a graduate from Institute of Medicine and currently working as a lecturer in University of Plymouth. So I would like to hand over this session to him for the further. Mahesh Raj Joshi, sir, please.
Thank you, Neeraj. Is the screen visible at the moment? Yeah.
Yes, sir.
Yes, it is. Yeah.
So today I'll be talking about amblyopia. So basically, I'll be talking about more about the research in amblyopia treatment and what is the current management option that is scientifically proven in amblyopia. So before I start, I just wanted to have a little bit of introduction of myself. So as Neeraj said, I did my undergrad from Nepal Institute of Medicine in 2003. Then I did my master's from Norway, University of Southeastern Norway in 2011. Then in 2016, I completed my PhD from Glasgow Caledonian University. So in terms of work, I've worked in, currently I'm working as a lecturer in University of Plymouth since last 2 years, but before that I was in Trinidad working as a lecturer, and before that I worked in Nepal and for a short time in Maldives as well. So, yeah, so in terms of today's lecture, we'll be going through some basic pathophysiology of amblyopia and commonly affected visual functions in amblyopia. And our main focus will be on management based on the current evidence. And I'll also be talking about some newer treatment that is being used for amblyopia in mostly in research kind of field. So just before the start, I want you to join a quiz. So if you go to slido.com and put the hashtag of E794, so the question is, what is the site of defect in amblyopia? So is it retina, optic nerve? Is it striate cortex or primary visual cortex, or is it somewhere in extra striate cortex? So if you go to the slido.com and enter your answers, then we'll see the results in a moment.
Causing people not to.
Okay, that's fine. So yeah, so we'll carry on then on this one. So yeah, so it is the correct answer. We know that retina and optic nerve are normal in amblyopia, and then the defect lies in primary visual cortex and beyond that as well. So I just wanted to go through the research of how amblyopia came to the forefront in terms of field of research. So primary, so Hubel and Wiesel, these are the primary people in vision science who have researched the effect of visual deprivation, firstly in the cat model, then in primate model in monkeys, and they also won the Nobel Prize for Medicine in 1981. So what they basically did was they characterized the function and organization of the primary visual cortex. So most of the research in amblyopia originated from their work in 1980s and before that as well, right? So in terms of how visual system works, just the kind of introduction to it. So as we know that the visual sensation is captured from optic nerve and it's transferred to lateral genital nucleus, LGN, and from there it goes on to primary visual cortex or in V1, right? So up to the primary visual cortex, the information from both two eyes are segregated in different layers. And it is the primary visual cortex where the information from these two eyes are first combined to provide us with the visual sensation. So in the primary visual cortex, there is a hypercolumn which consists of ocular dominance column. And the ocular dominance column basically contains information coming from right eye and left eye in an organized manner, as well as it also has orientation column that responds to a certain orientation. So if you look at the cells from primary visual cortex, as I said before, this is the first place where the binocular cells are present. We can see that in this graph. This is not the actual graph, but just to give some idea about that. So there are the cells, ipsilateral cell meaning by the cell responding to one eye, and contralateral cells meaning the cells responding to the opposite eye. But in between these two, there are some binocular cells as well, which basically responds to stimulus coming from both eyes. So that's why we know that that's the first area where these binocularly driven cells are present in terms of ocular dominance column, right? So in Hubel and Wiesel study, what they did was they used occlusion to characterize the primary visual cortex cells and how occlusion can affect this dominance column in primary visual cortex. So when they occluded sutured the eye of one eye, so sutured the eyelid of one eye, what they saw was that the primary visual cortex was now dominated by the non-occluded eye only, right? So all the stimulus in primary visual cortex, or all the stimulation, was only coming from the one eye. And when they induced strabismus in the cats and later in the monkeys, they found that it also caused the loss of binocularly driven cells. So you only had monocular cells present in the primary visual cortex in ocular dominance. So this kind of formed the basis of how primary visual cortex changes in response to any kind of stimulus deprivation or strabismus. And from that, we learned about amblyopia in kind of a scientific way, right? So another question, I hope this works better. So do we know what aspects of vision are affected in amblyopia? So we commonly know that visual acuity is reduced, but apart from that, what other kind of visual functions are affected in amblyopia? So if you go to slido.com again and try to use the hashtag and see if it works this time without the yeah, so we got one answer, binocular vision. So we'll give another 30 seconds for this, then we'll move on. So contrast sensitivity, accommodation. Yeah, so stereopsis, motion perception. We have ocular movements, saccades, smooth pursuits. Okay, so I think most of the responses have been concentrated on binocular vision and some contrast sensitivity, and some accommodation as well. So moving on from here, so as you correctly pointed out, like most of you wrote contrast sensitivity as well. So apart from your visual acuity and crowding, which are the most like fundamentally examined visual function in clinics, there are other visual functions that are also affected in amblyopia. So for take example, like contrast sensitivity. So in the bottom right corner, this is the normal contrast sensitivity, what you'd expect in normal humans. And in strabismus, as you can see that the fellow eye still has follows a good contrast sensitivity function, but amblyopic eye has reduced contrast due to amblyopia there in strabismus amblyopia. And this becomes even more kind of obvious in deprivation. So example, in your stimulus deprivation amblyopia, you can see that there is quite a reduced contrast coming from the deprived eye. And for anisometropic amblyopia, it's a kind of vertical shift. So there is a reduced contrast all over your different spatial frequencies, right? So this, apart from your contrast sensitivity, there are other different functions that are affected in amblyopia, which are being investigated in more recent times. So as somebody's rightly pointed out, motion sensitivity is affected in amblyopia. So this is the random dot kinematograms, which are mostly used to study motion perception. Form perception, for example, like your shape, orientation, those are also affected in amblyopia. And another interesting thing is, like, when we talk about amblyopic vision, like, we clinician only think about visual acuity as a kind of measure of what they are seeing. But in this interesting experiment by Barrett in 2003, they found that even their perception of their sinusoidal gratings or Gabor patches are also affected in amblyopia. So instead of seeing a straight sinusoidal grating, they are seeing some kind of distortion there as well. So in addition to that, as rightly pointed out, there is defect with your eye movements, so your saccades, your smooth pursuits, all of those are affected. And more recently, it has been shown that even face perception is altered in amblyopia. So in terms of what I want to take away from that is, like, when you think about amblyopia, don't only think of that in terms of your visual acuity. Just think about all these different host of problem that the person might be experiencing, right? So this is another kind of image in terms of what amblyopic vision might look like. So in the top picture, you might see that this is a normal kind of image that the person sees. And if there is reduced contrast or weak signal, the person might see something like this. If there is kind of blur, the image might be quite reduced in all the different spatial frequencies. And there might be some spatial distortion as well. So if you mixed all of these three together and even more other different functions that are affected, so you can kind of try to imagine how the amblyopic vision might look like. So it's not only the acuity that we need to consider when we're thinking about amblyopia, right? So moving on to clinical investigation, like when we practiced in Nepal and in different countries, we mostly focused on visual acuity with the Snellen chart, logMAR chart, or whatever. And most of us knows about crowding. So crowding is kind of exacerbated in amblyopia, which crowding is kind of a normal phenomena which occurs even in normal peripheral vision, but in amblyopia, crowding is quite common. So that is kind of one of a distinctive feature of amblyopia. So when you're taking visual acuity, make sure you use single letter chart as well as crowding chart. And this is particularly important when you are treating amblyopia, so that when you do patching or any other intervention, then you need to make sure that you are taking visual acuity with consideration of crowding as well. So in terms of recording that, you might write, when you record visual acuity in amblyopia, it might be important to record visual acuity from this single letter chart as well as from crowded chart, and see how that changes with your intervention, right? So in addition to that, cycloplegic refraction is probably the most commonly used investigation. So after we have ruled out any pathology and we still see that the visual acuity is reduced, most of the clinician will start to think about amblyopia, right? So that's quite a common kind of perspective we have. But what we need to remember is, I've not gone into the detail of that. To diagnose somebody as an amblyopic, you need to have some feature of amblyopia or cause of amblyopia present there. So in addition to non-improvement in vision from refractive correction or from pinhole, you need to consider if there is actual cause of amblyopia present there or not. So there are three causes of amblyopia. One could be anisometropia, strabismus, or stimulus deprivation. And sometimes if there is binocular, bilateral vision loss, then it could be due to the high refractive error in both eyes as well. So before saying that this is amblyopia, make sure you try to find out if there is any causative kind of thing that is present or not to call it an amblyopia. So on the right-hand side corner, this is the Bagolini filtered glasses, or sometimes called Spisa bar. So this is kind of a different thing that I experienced when I moved to UK, which I don't think we have used this in Nepal. So this is the one that we use to measure suppression. So using this instrument, what clinicians do here is they put the colored filter bar in the good eye, and they ask the patient to focus on a bright light. So if patient is fixating from the good eye, they will see a red light instead of white light. And as you increase the density of the filter, at some point in time, the fixation changes from your good eye to the bad eye, or the amblyopic eye. So in that point in time, the fixation will change from red light to the white light. So this is taken as a kind of a amount of suppression that is present in the amblyopic eye. And this is kind of taken as a kind of important feature when you are treating amblyopia with patching, so that you do not cause intractable diplopia after lifting the suppression, right? So I'll come to this again when you talked about management. So this is one of the different things that I saw being practiced in mostly in UK. So we'll come to the treatment, because I want to focus more on the treatment side of amblyopia. So amblyopia as a condition is known from quite a long time. It's probably from the time like 850 AD is the first time that the term amblyopia was coined. There is a record of that. So from that time, there has been different kind of treatment that has been used in a hope of treating amblyopia. So you can see that there are lots of kind of different treatment that we might think is like kind of pseudoscience almost. So suturing eyelid, diet of wine, eyeball massage, acupuncture. So all of these different kind of treatment have been practiced over the time from 850 AD or whatever. So it's been, so amblyopia has a quite long history of treatment, and it differs throughout the time that you look at, right, historically. But in current scenario, we know that the main treatment is refractive correction followed by patching. So this is the most commonly utilized treatment modality for amblyopia all over the world. And in recent times, there has been a newer method, not the newer method, but it's still based on the same kind of principle, but using atropinization and doing near work while you're patching. These are the main kind of treatment that is used universally for treatment of amblyopia. Right? So I'll go through each of these evidence for each of these different treatment modality for amblyopia one by one. Then I'll summarize what is kind of scientifically proven treatment method for amblyopia and the doses of these different kind of intervention. So most of the research that contemporary research or modern day research in amblyopia treatment comes from amblyopia treatment studies, which is conducted by Pediatric Eye Disease PEDIC group. So I'll be talking about most of the research from their group in next few slides. So first, let's start with the refractive correction. So good cycloplasic refraction and full correction of any refractive error is kind of the first basis of amblyopia treatment. So if there is amblyopia, what we need to consider is, like, generally when we do cycloplasic refraction, we tend to, after the in post-cyclo evaluation, we tend to reduce the amount of hypometropia that we find to account for the loss of accommodation during cycloplasia. But if there is any kind of esotropia or any kind of amblyopia that you suspect, then it is recommended that you provide full cycloplasic correction, so without reducing any amount of diopter for your loss of accommodative tonus, right? So that is the recommended kind of refractive correction that you need to do for amblyopia, as well as any kind of esotropia or in any other developmental disorder. So another interesting thing that we found was, like, from my experience, like when we were in Nepal, when we use cycloplasic agent, it takes quite a long time to cycloplase the patient's eyes. But here, especially in UK, with the normal irises, or not the normal, but the light color irises, it's quite fast to cycloplase somebody. But when I was working in Trinidad, which again had quite dark irises, it took us like maybe sometimes 1 or 2 hours, or even we had to come and use atropine very often, right? So as I said before, a refractive correction is kind of one of the first intervention that you'll perform in amblyopia. And it has been shown that around 25% of amblyopia is resolved just by the refractive correction. So this is for all type of amblyopia, not only anisometric or refractive amblyopia, but even for strabismic or even combined mechanism where there is both anisometropy and strabismus. Around 25 to almost 40% of the amblyopia is resolved just by using refractive correction. Right? So this is another kind of intervention that we think we take lightly, because from our practice, from my practice, especially from my personal practice in Nepal, this was a long time back, but we used to prescribe patching right away after we have prescribed the glasses, right? So what we need to remember is almost around 25% of the amblyopia could be treated just by refractive correction. So another question comes in: how long should we wait before we start patching once we have prescribed the glasses? So in the same research, what they found is this is the top one is for strabismic amblyopia. So most of the visual gain just with the refractive correction occurs within 18 weeks of refractive correction. So once you have prescribed glasses, you should at least wait for 18 weeks to see if amblyopia resolves just with the refractive correction or not. And this not only for the strabismic amblyopia, even for combined mechanism amblyopia, it's still around 18 weeks. And as you can see in the graph here on the right side, some people were still improving beyond 18 weeks up to even 36 weeks. But I would say, like, once you have detected amblyopia and we will prescribe glasses, at least wait for 18 weeks to see if refractive correction alone would be adequate to improve the amblyopia or not, right? So that is the kind of main treatment, main kind of intervention through refractive correction. So next I'll talk about patching. So patching, as I said, is the most common treatment of amblyopia. So in the next study, in a graph here, you can see that in the x-axis, there is the total dose hours, so total amount of patching, amount hours, and change in visual acuity. So from this graph, what I'm trying to show is the treatment dose relationship between your patching and visual improvement occurs up to around 400 hours. So cumulative 400 hours of patching is, after that, you would not expect there to be significant improvement after you have crossed this 400 dose hours. So for example, if you're prescribing 4-hour patching per day, then if the patient sticks to that, then after 100 days of patching, then you would not expect that many improvement just with the patching. And also, like 75% of the improvement occurs within the first 6 weeks of patching itself. So after that, the patching might not be that much, might not provide that much fast improvement. Right? So another graph here on the right-hand side, again, this is the dose relation. So we always have this problem with how much amount we should prescribe to patch, because as we know that patching is kind of difficult intervention in terms of child as well as parent. It has its own kind of psychosocial implication, like bullying in the school and so on. So we need to know that how much dose or how much amount of patching should we do for different types of amblyopia. So in this example, like in this study, all the participants, the 94 participants were prescribed 6-hour patching, but when they monitored the dose using sensors and so on, they found that most of the children only passed around 4 hours a day, right? So even with 4 hours a day, you are still getting the improvement that is being shown on the left graph. So what I'm trying to say here is, like, we need to make sure that we are prescribing right amount of patching so that the patient compliance with the patching improves, as well as we are not prescribing unnecessary patching and creating side effects of that, right? So we'll go to more of that. So we talked about 4 hours of patching being adequate. What about for severe amblyopia? So in this study, they looked at patching 6 hours a day to full-time patching. So when we talk about severe amblyopia, we're talking about quite poor visual acuity, less than 660 or less than 630. So our natural tendency comes that we should prescribe maybe more patching and hope that we'll see a quick recovery. But this study has shown that, like, there are two groups. One was given 6-hour patching, one was given full-time patching, and they observed them after 5 weeks and after 4 months. So as you can see that here in both groups, the gain in visual acuity was same. So prescribing full-time patching is probably not useful. It doesn't have any scientific merit. Even for severe amblyopia, 6-hour patching is more than adequate, right? So, and this is even the case for quite deep amblyopia. So even if the vision is around 20/250, so that would be around how much? 690. For severe amblyopia, what about for moderate kind of amblyopia? So in terms of moderate amblyopia, we're talking about visual acuity between 612 to 624. So in this study, they found that even 2 hours of patching provides same kind of improvement in visual acuity compared to 6 hours of patching for moderate amblyopia. So take away message from this is like, if you have severe amblyopia, visual acuity is 630 or less, then 6-hour patching is more than enough. If it's just the moderate amblyopia, 612 to 624, then 2 hours patching provides the same kind of improvement as your 6-hour patching, right? So there are different studies from the same group, amblyopia treatment studies, and there are different studies that they have looked at different amount of doses of patching and so on, and different age groups. So I'm just summarizing all those research here. So in children less than 7 years of age, 6-hour patching is enough, even for severe amblyopia. For moderate amblyopia, 2-hour patching is adequate. And for children less than 8 years of age with any kind of amblyopia, 2 hours of patching improves visual acuity better than glasses alone after the refractive adaptation has been completed, right? So this again points to us the importance of first waiting for refractive adaptation, then follow that up with right amount of patching, either 2 hours or 6 hours or 4 hours, depending upon the severity of the amblyopia. Another interesting study that this group did was in older children between 7 to 18 years of age. In them, they found that patching 2 to 6 hours a day improves at least 2 lines even in older children, right? So, but this is more dependent on if they had any treatment before as a child or not. So if you had a treatment patching as a child earlier, then the patching might not work. But if the patient has not had any patching before, then even in older children, prescribing even 2 to 6 hour patching can improve the visual acuity. Okay. So next we move on to atropine. So 1% atropine sulfate has been used quite commonly for penalization process of amblyopia. So again, like we're looking at here, the graph that shows comparison between patching and atropine, right? So 2 groups, patching group and atropine group, and the difference in visual acuity as they go through this process, right? So as we move along the y-axis, this is the gain in visual acuity. So as we go up, that's better. So in the 5 weeks, you can see that the atropine group has quite a small improvement in visual acuity, but as we go along up to 16 weeks and 6 months, the improvement in visual acuity either through patching or through atropine is almost similar, right? So this is for amblyopia with moderate amblyopia between 612 to 630 only, right? So just prescribing atropine instead of patching, which again you'd expect better kind of compliance from the patient and reduced kind of psychosocial effect on child. So atropine works quite well for moderate amblyopia. So what if we reduce the dose even further? So in this study, they looked at prescribing atropine only on the weekend. So when atropine, as you know, that it has its own side effects, so we want to make sure that the dose is as low as possible, that is adequate to improve the vision. So in this study, they found that even instituting weekend atropine, so atropine over Saturday and Sunday is adequate to have same amount of visual improvement. So this is in the baseline as we go along. So this is in 5 weeks examination and so on. So So just prescribing weakened atropine is adequate for moderate amblyopia. So they also did study for atropine on severe amblyopia. So severe amblyopia meaning by visual acuity less than 630, but they couldn't find kind of substantial improvement. So they did find improvement, but it was not like statistically different from patching. So I'll come to that in a moment. So another kind of, another area of treatment that clinician mostly prescribe for amblyopia is, in addition to doing your patching and your refractive correction, some clinician want the child to do near activities, right? So near activities meaning by some coloring stuff and some kind of concentrated near activities like this that are shown in the images. So the amblyopia treatment study also looked at this. So what they found was, in this study, they prescribed just distance activity to one group of children and near activity to another group of children. And they didn't find any difference between these two. So basically prescribing this near active treatment in terms of coloring the books or putting the thread through, threading and those kind of stuff, this is not scientifically shown to have any effect on visual improvement, right? So just to summarize this atropine and near activity, so atropine provides similar gain compared to 6 to 8 hours of patching for moderate amblyopia. Atropine definitely has better acceptance and concordance. So concordance meaning by compliance to the treatment. And reduced atropine, just prescribing atropine over the weekend also has same effect as your patching. But there is currently no concrete scientific evidence to show that amblyopia works as good as patching for severe amblyopia. Right? So if the visual acuity is less than 630, then atropine might not work that well compared to your moderate amblyopia. So in terms of near activity, there is again no concrete evidence that prescribing near activities improves the amblyopia treatment, but we need to be careful here that these are just the common near activities like your coloring and so on. These are not kind of clinical vision therapy that are aimed at improving accommodation or lifting suppression and so on. So there is, this has not been studied so far. Okay. So we've come to the treatment part of that. So as I went through the slides, I showed you that some of the studies have shown that even treating children up to 18 years would help with amblyopia. So there is another poll. What is the maximum age that you have successfully RX for amblyopia in your clinical practice so far? Up to what age have you seen improvement in the treatment? So if you go back to slido.com again and use the hashtag to put in the answers. Yeah, 12. So 35 years, again, that's quite a lot. I'll give you 30 more seconds. Okay, so kind of 13 to 19, 12, 20. So 35 years seems to be up to 30 years. So hopefully you have had success with even the older children or older adult, I should say here. So we'll move on to the next one now. So when we talked about in the very first few slides, I talked about how Hubel and Wiesel used suturing techniques. So when they sutured the one eye of the cat or monkey, they looked at the visual effect of visual deprivation on primary visual cortex. So what they found was if you reverse suture these animals again, like for example, at the start you suture their right eye, and you looked at their primary visual cortex. Then after 3 to 8 weeks, they sutured the left eye and provided the more stimulation to the right eye. So what they found was when you do reverse suturing, the visual acuity or visual function in the previously deprived eye improves if you do the reverse suturing up to 3 to 8 weeks and slightly beyond. But after 1 year, if you reverse suture after 1 year, they didn't find any kind of improvement in the previously visually deprived eye, right? So from this kind of experiment, traditionally we felt, or it was said that the critical period of development is up from 7 to around 9 years of age. And the prevalent kind of thinking was that if you do amblyopia treatment beyond this age, the visual acuity would not improve, right? So, but as I showed before, like in the pediatric study itself, they found that up to 18 years of age, the visual acuity could still improve. And in some studies, like in one of the studies that looked at the amblyopic patient who developed AMD in their late 70s or 80s. So what they found was like when the AMD developed more severely on their normal eye, the visual acuity in the previously amblyopic eye started to improve. So this shows that there is not a set kind of critical period of development of the visual function, and our visual system is quite malleable, and this points us to continuous development of our visual system and tells us that we could probably treat amblyopia even later in the life, right? So keep that in mind. So next I'll talk about some new treatment that are being used mostly in the research setting for now, but which might transform the amblyopia treatment in future. So first we'll come to why new treatment is needed. So we know that patching works quite well in most of the children. We know that refractive correction works for most of the children, but why do we need new treatment? As I said before, like patching has its own kind of issues in terms of compliance as well as the psychosocial impact on child. So that's why there has been like new emphasis on trying to find new treatment. Similarly, if we think about it, like amblyopia is a binocular problem, right? So there is a poor coordination between the two eyes that causes amblyopia. And from the definition itself, it's a binocular problem. And the patching treatment that we used is a monocular treatment. So we are treating binocular condition using monocular treatment, right? So as you know, the patching leads to loss of stereo acuity and all other kind of function associated with the binocular single vision as well. So the hope is to find a newer treatment which can be used to treat the condition binocularly rather than using monocular treatment of patching, right? So perceptual learning, this is a kind of technique that is being explored for the treatment of amblyopia in recent times. So perception, when I talk about perceptual learning, it means that like when a human visual system performs a task repeatedly, it results in improved visual function. So in a simple way, we can think about convergence exercise. So when we do convergence exercise, the visual system starts to improve again and your convergence develops, right? So that points us towards some kind of plasticity in our ocular as well as visual system. And what they found was when you do perceptual learning, so let's start with what perceptual learning is. So for example, in the typical kind of perceptual learning paradigm, a patient or a participant performs a kind of 1,000 or more than 1,000 trials on a specific task. So for example, to find the orientation of the Gabor patch or the movement of the dots in this experiment, for example, or even hyperacuity tasks, for example, here, right or left from the vertical or dissociation from vertical. So once you perform these experiments or these tasks repeatedly over sometimes over 1,000 trials, then your ability to do this function improves. So your ability to detect motion, right or left motion improves, your ability to of hyperacuity also improves, and so on and so forth. But what they found interesting was once the patient is trained on, or a participant is trained on a specific task, it also results in the improvement in other tasks, such as in Snellen acuity, right? So if you practice the Vernier acuity for a long time, research has shown that that also results in some improvement in Snellen acuity, right? So this kind of experiment was thought to be quite useful for treating amblyopia then. So as I said, it results in improvement in Snellen acuity as well. So nowadays there are lots of games that use the same technique of perceptual learning, but using video games. So if you imagine, like, if you ask the child to find the orientation of Gabber paths right or left 1,000 times or 2,000 times, the child is going to get bored and he's not going to do that task, and that will not result in successful improvement of the visual function, right? But what interests the children more, we know that the video games or any type of video game or any type of gaming activity would be more useful to get child's attention, right? So in this study done in 2016, so not that long ago, what they used was video gaming technique. So in this game, some characters are in red, and the base where they have to jump to get the higher score are in blue color. And in this game, they will use red and green dissociation or red and blue dissociation. So one eye will only see the character, and the another eye will see the base. And if the child plays this game often, then this is a kind of perceptual learning paradigm that is used. So in this study, they found that the binocular gaming improves the visual acuity as much as patching does, right? So here, as you can see here, this is the baseline where the binocular gaming had a slightly better acuity compared to the patching group. But as they went on in 2-week visit, in the group that were only playing video game, the visual acuity improved by more than 1.5 lines, whereas in patching group, it only improved by around half line. So this was a kind of study that showed that video gaming could be used to improve amblyopia, but this study was not powered well, so that's why, even though it is a randomized clinical trial, this study was not powered to give you a concrete evidence saying that video gaming could be better than patching, but at least it shows that this kind of treatment modality could also be useful, right? So in the next, this is another perceptual learning paradigm that I worked after my PhD in Glasgow. So in this one, instead of using simple games like that, we use off-the-shelf action video game. And so for example, here, we'll send the high contrast image to the amblyopic eye and the low contrast image to the good eye. So in a hope that when you send the high contrast image to the amblyopic eye, it will improve the visual acuity of that patient, so on. And on the bottom right here, you can see that you could, as the patient plays this game continuously, as the child progresses, you can change the level of contrast that goes to each eye so that you can keep the visual learning going on. And you can also correct for strabismus by changing the distance, changing the versions going to the two eyes. So in this paradigm, what we do is first we put the child on a kind of a virtual reality headset. We correct their strabismus using change in versions for each eye. Then we use contrast equalization. So what we ask the child to do is to tell if the both images from each eye looks same or not. And we change the contrast till both eyes sees similar contrast images, and we ask the child to play the video game for 1 hour a day. Right? So
you can get really.
A child also recognizes the orientation of these Gabber paths. They will get more reward within the game, like more life or more ammunition and so on, right? So So one of the results from one of the arm of this study has just been published in 2018. So here the squares are kids and the red squares are adults and different amblyopia types, right? So as you can see here, in the kids, the visual acuity improved almost 1.5 line after around 15 hours of gameplay. So without any patching or without any kind of intervention. So also to add, these are the kids that were already that had already gone through their patching, and they had been released from the patching treatment because they didn't improve further. So we took those children, and then when they come into the video gameplay, just with the video gameplay, they improved around 1.5 lines within 12 to 15 hours of video gameplay. And even for the adults, like adult amblyopes, they still showed around 1 line of improvement of around 15 hours of gameplay. Right? So, and this was true for both anisometropic as well as strabismic amblyopia. So yeah, that was the last slide. So these are the references, and if there are any questions, you can